talk about is what happened to spine radiosurgery, because as Per alluded to, there was a lot of initial excitement, just like any new type of technology or indication. But now, as I'll show you, we're really in the field of trying to prove it because we've established it and how to do it safely. And that's also going to be what I talk to you about. So spine SBRT has really emerged as an alternative to conventional radiation. We are talking about dose escalation for spinal metastases while sparing the spinal cord to a tolerant dose. And we just didn't have the technology before. And we didn't have the philosophy of treating patients with spinal metastases aggressively, much like the story to brain radiosurgery. And there's a beautiful parallel in terms of what's happened in over 30 years with brain radiosurgery to what's happening right now with the spine. It's a bit more scary in the sense that we do deal with radiation necrosis in the brain, which can be surgically managed or managed with medications. What we have to worry about in spine is that if we fracture that vertebra and collapse it, and the patient is then subject to an operation, that operation can sometimes be really quite significant and have an overall negative impact in the overall patient's trajectory. So it is a different beast. There are different surgical risks, and these are the things that we have to think about as we go forward, and I'll show you some of the data. So we have about a decade of published experiences now, and the common doses that we use, 35 to 40 gray 5 fractions, 24 and 2, which is what I use. Then there's 24 and 1, and I think there was some excitement about this, but it's kind of died down as we've realized some of the toxicities associated with giving too much. And there is also a spectrum in terms of how what you can give safely to maximize local control, but you can do harm. So we're going to go over what we've learned in terms of outcomes and potential serious adverse events. So in terms of outcomes, it's really mainly single institution data. Now, some of us put our data together as part of a spinal consortium, and we came up with 387 de novo spinal metastases. And you can see here that the local control curves are really quite high. And these tend to be complex, bulky, or mass-type lesions. So I think we're doing well in terms of local tumor control. With conventional radiation, with bulkier tumors, you can only expect maybe about 50% local control over time. So we were happy with this result. And the other indication that we were looking at as a consortium is the reirradiation cohort. And this is an excellent indication for spine SBRT, because in a patient with previous radiation, say they had 20 gray 5 fractions, then they have some progression or worsening pain, what is the typical practice of conventional radiation? And that's to give a lower dose of radiation the second time. So it's completely not intuitive with our strategy to maximize local control. If it didn't work the first time with a dose of radiation, how is it going to work the second time with an even lower dose? So strong rationale for spine SBRT as we've learned what the tolerance is to the spinal cord in the reirradiation scenario. And again, very similarly, we had about 13% of patients having local failure, and you can see the curve here with about 80% local tumor control. And again, very reproducible amongst the series, and this was, again, a multi-institutional collaboration. Now, what's probably more exciting are areas like renal cell carcinoma. So these metastases that have been considered radioresistant. Now, in the brain, we've been doing radiosurgery for years, but there was always a dogma in terms of extracranial metastases that medical oncologists wouldn't even send the patient for radiation because it was felt that it didn't work. And it's only because we have the ability to dose escalate and give sufficient dose that we're now seeing local tumor control. And we have 1-year local control rates of 80% in our series, very reproducible amongst the other series reporting specifically on renal cell carcinoma. Now, sarcoma, extremely difficult metastases to control, especially when it's in the bone. And again, we're seeing very high rates of local tumor control on the order of 80 to 90%. So what have we learned globally in terms of radiosurgery in the brain and stereotactic body radiotherapy is that there may not be this concept of radioresistance anymore. It's just we never gave enough dose smartly. And so now we take out that phenomena of radioresistance in our lingo. Now, there are many people who are skeptics, and they say, well, local tumor control is great, still survival is a major issue, and that's true. what if we hurt the patient and we don't give them pain control, even though we're inducing local tumor control? And the best data are from this series from the MD Anderson. So they look at prospective study, 27 to 30 gray in 3 fractions. And what they found was that their complete response rates to pain actually start coming up to about 50% over time. And this has now been reproducible in other series. High quality data that you can actually achieve a complete response to pain. Now with conventional radiation, when you apply proper endpoints, this rate does not exceed 10 to 20% in the large randomized studies. And so we have now the rationale for local tumor control, and you have the rationale for pain control. But what's most impressive with this technique is really that you can see the tumor shrink. And you can actually induce ablation, if you want to call it. I think someone's calling somebody. And actually see a tumor respond. And you don't see this with 20 gray in 5 fractions or 30 gray in 10 fractions. It just doesn't happen. But it happens here, and the question is why? And this is where the phenomena of the biology comes in. The Memorial Sloan Kettering were the first to break the story on the sphingomyelinase pathway, inducing microvascular dysfunction in the tumor endothelium as a unique pathway. And now we have in vivo data looking at plasma ceramide concentrations that you can see complete response and partial response rates in conjunction with plasma ceramide. So now we have an in vivo marker of who's going to respond and who isn't going to respond. And very interesting. And this is only going to grow with further data from Sloan Kettering. But this was the first trial to break this story. Now, we have some functional imaging. Maybe you should dance while you're doing it. It's kind of strange. I've never done a talk like this before. Yeah, that's all right. So then, we have in vivo perfusion. We have in vivo perfusion imaging. So this is a great story. So this is an L4 metastases that was treated. You can see it gets a little bit bigger, stabilizes out. And what's happening there? And we have a big challenge with the use of conventional MRI to understand what's happening in these lesions. But if you look at the perfusion imaging is completely dropping out. So we are in the era now of combining functional imaging with conventional imaging to understand response. But it tells you a little bit more about the pathophysiology of response, which is something that we're learning. And just like everything else right now in our current lingo is immunotherapy. And what we've seen here from Silvia Fermenti's group, and as Matt showed also, you can enhance local tumor control and cause potentially an abscopal effect with the combination of radiosurgery with these agents. And it may be better to fractionate them a little bit to optimize that response. But it's, again, new biology and a new realm of thinking as to what we're doing with these high doses. And in fact, one of the first reports of an abscopal effect in melanoma actually arose from a spine met case. And they treated this patient 9.5 gray in 3 fractions, and they saw a response in the brain and the lung and the liver. So it's a very interesting new era. We're trying to understand this further. So how do you do it, and why did it take so long for us to get there? And it took us so long because we didn't have the technology. And we have multiple forms of technology. What's critical and similar to all of these is that we're dealing with the image-guided radiation, and you have to have an MLC of under 1 centimeter for spine SBRT. So we built our technique, and Matt was with me when we were building it, and we put basically the limits of technology together. So we immobilized patients in this kind of bodysuit and saran wrapped them in there, and we used a sub-centimeter MLC, 4 or 5 millimeters, and we use thin slice MRIs. Some patients we actually myelogram now. We're doing all of this so that we can accurately visualize the target and the spinal cord and treat them with image guidance with positional verification with all 6 degrees of freedom. So really putting it to the limits. And you need it because every millimeter counts in spine SBRT. If you're off by a millimeter, you can increase the dose to the spinal cord by 5% and sometimes even more. So who should get it? Because you're probably saying, oh, that's great, I'm going to treat all my patients with spine SBRT. Well, you can't really. You have to be selective just like everything, including in the brain. there are different categories of metastases that we have to be aware of now, and actually much more in tune with our surgical colleagues so we can communicate with them better, because it is now more of a collaboration with neurosurgery or orthopedic spine, just like it was in the brain. But it wasn't like this for us before. It was more, if a patient was in cord compression, we're going to pick up the surgeon, call him, can you deal with this? As opposed to talking about cases before you actually treat them. And you have patients with paraspinal disease, epidural disease. Here, if it's not symptomatic, would a surgeon operate? Probably not, but now we're shifting that, and we're doing more surgery for patients with higher grade epidural disease. You have patients with vertebral compression fractures or marrow confined and relatively simple lesions. But all of these have their own unique situations or characteristics for spine SBRT. But one of the first things that you have to do in terms of communicating properly with the surgeon so that it's easy for you to go over cases, and especially in a multidisciplinary tumor board, is to understand the grade of epidural disease. And we never really did this in radiation oncology. I mean, we saw epidural disease on a report, and even if you have something like this, which is touching the cord but still CSF, that doesn't need a surgery. But typically, you'd see a report, epidural disease, either you rush to radiation or you call the surgeon. And that's no longer the case. In these situations of a Bilski 3, so complete cord compression, that's a different story. But for lower grade epidural disease, even if there's a little bit of minor compression, you have the time to think and do more potentially for that patient than simply quickly palliate them and give an ineffective dose of radiation. And this issue of epidural disease is really kind of increasing in our literature. And we were one of the first to actually report a relationship between local tumor control and grade. And we did this by looking at our postoperative series. So you have a patient here with high-grade preoperative epidural disease, gone for surgery. The surgeons took out the posterior elements and left some space, decompressed the cord, and then I come in and I say, well, look, I'm not going to give this patient just a palliative dose of radiation. They just went through all the surgery and 1 month of rehabilitation. I want to locally control this patient. Look how much tumor is left behind. I'm going to treat the entire area and treat it with what we call a donut distribution. And it's not because we love Tim Hortons that we call it donut. It's because we're treating everything all around it. You got to treat all that surgical area because it can fail anywhere. And we have been quite effective in our approach, where we have 1 year local control rates in the order of 80%. But moreover, I was interested in the relationship of epidural disease grade and local tumor control. So you can see here, our guys did a good job. We had about 60% of high-grade epidural disease, down to about 10% and only Bilski 2. So we looked at our data, and we found on multivariate analysis that the grade of postoperative epidural disease predicted for failure. So if you had a 0 or 1, you had a good chance of local tumor control. If you remained at 2, you still had a drop in your local tumor control rates. So it was rationale to do more, and we are doing more for higher grade epidural disease using more novel surgical techniques, which I'll talk about. The other area that you have to consider, and probably one of the most important areas right now in the field of spine SBRT, is the concept of spinal instability. So you have a patient like this with melanoma, high-grade, some degree of epidural disease compressing the cauda equina, but this patient didn't have neurologic deficit, but this patient had excruciating pain when he walks, when he picks something up. This is mechanical instability. But I didn't have the time to get an operation because the patient's liver disease was exploding, everything was going bad for this person. So I talked to him and I said, well, look, I can treat you with spine SBRT and give you a chance of tumor control, or we can just quickly get onto some palliative radiation and see how you do systemically. Your risk of further fracture, let's just take a show of hands. If I treat this patient with high-dose stereotactic radiation, 10% risk of fracture, 30%, 50%, it's about 30%. You know, we have the data, we've reported it, and I said, look, you got a 70-30 chance. If you do, it may go badly. So he goes, no, I want to do it. I did it, and we got him through this process. He was on treatment within 2 days, and he went, lo and behold, he fractured. And then he went into symptomatic cauda equina syndrome, and we had to operate anyway. So it's complex and it's hard, and we have to understand better who is the best patient for this techniques, and could I have just prophylactically stabilized them in the first place and avoided potentially disastrous situation? And with that, you have to understand the concept of instability. The SINS is a very nice classification tool, looks at location, mechanical pain, if you have lytic tumor, spinal malalignment, if you have vertebral body collapse, very important, and if there's posterior lateral involvement. And at least if anything, and we've done some work to validate some of this, you can communicate quickly with your surgeon. I know I run it in my head, I pick up the phone, I call my surgeon, I go, this. He goes, no, don't worry about it, it doesn't need anything. As opposed to, okay, yeah, maybe I'll see it in clinic, because they understand now that we're talking the same language. We've incorporated this into some guidelines, talking about the ideal patient with low-grade epidural disease, no spinal instability. But patients who are excluded from SBRT are high-grade epidural disease and, frankly, unstable. So at least we're starting to work these concepts into radiation oncology practice. So I want to talk about toxicities because I've shown you that we have got good rates of local tumor control. We've got a decade of experience, almost 2,000 patients treated in published literature. What have we learned in terms of safety? Because it's safe now. You can do this and you can pick your patients appropriately. One of the issues with safety was really radiation myelopathy, and that was the scare. But we looked at the data and we published numbers. I've treated over 1,000 patients, no case of radiation myelopathy when you abide by these numbers and these caveats, both in the re-irradiation scenario. So we have the numbers. This is not a barrier anymore to the adoption. But fracture is, and I think this is the one area that I've invested the most time now in the last 5 years of looking at fracture. And we did the first step by putting our data together. So we put our data with the Cleveland Clinic and MD Anderson, and we looked at our fracture data. And we said, oh, we're doing pretty good. 14% vertebral compression fracture rate. So we're happy, and it wasn't until we really looked in the data and did a multivariate analysis that we understand who were at high risk. Vertebral body collapse, your relative risks are increasing dramatically when you're greater than 50%, spinal malalignment, lytic tumor, and high-dose perfraction. And one of the reasons why I did this was because the Sloan Kettering was coming out with 24-1 and a 40% risk of fracture. But they were saying that, look, our control rates are 90%, and I started doing it, and I started fracturing all my patients. It was just extraordinarily stressful, and I was not happy with what was happening with the patient. And we looked at the data, and it drove me to stop it. And I went to 24-2, and since then, I've never looked back. So if you take a patient like this with spinal malalignment, lytic tumor, and although no fracture, but a high burden, you're putting that patient at almost a 70% risk of fracture. Now, what's important here is you're at the cervicothoracic junction. That patient's getting a long construct, at least a week in hospital and rehabilitation. So you really have to select your patients properly. But don't be scared. I mean, there are consequences, and you have to think about it. And there are real gains for these patients. So in this patient that fractured 5 days later, when we looked at the pathology, there was no more melanoma. There was inflammation, but no melanoma. So he had the surgery. We went through that. If I treated him with 8-gray-1 or 20-5, we would never have made a dent in this person's tumor. So there is real ability to do better for these patients. But what's the proof, right? We talked about that and proof and randomized trials and everything. We do not have a randomized trial yet. We have the RTOG study of 8-gray-1 versus 18-1. That's been going on for almost 6 years now, and I'm not sure whether or not they'll finish. We hope so because we need it, but it's ongoing. Then we have the Canadian trial, which I lead, which is SC24. So this is a study, and we're doing well with this, mainly because we're using a bit more of a fractionated approach and a longer length for these patients of conventional radiation. So 20-gray and 5 fractions of conventional radiation versus what we developed, which is 24-2 of stereotactic. And I'm pleased to say we've randomized 30 out of 54 patients within 7 months. And we are very aggressive. The majority of them are from my center, but we're going hard after this to at least finish the randomized phase 2. Now, the primary endpoint is feasibility, but we'll have some high-quality randomized phase 2 data. So we hope to finish this, and we will finish this in 2017. Now, what's important, again, in terms of when we designed this trial, was using appropriate endpoints. So we developed actually spine oncology specific endpoints, and Matt was part of this group where we talked about issues of how do we measure local control, what's the pain tool, and we put that into the SC24 protocol. And we also started looking at the phenomena of repetitive imaging. So don't call something progression on your first spinal MRI. You have to look at it because we have the phenomena of osseous pseudoprogression. And in every site that we treat with high-dose stereotactic radiation, we have the phenomena of pseudoprogression because we're inducing tumor inflammation and early changes in the organ. So here's a case of true progression, and this was courtesy of my other fellow, Laura, and we've published this, and it's coming out in the Red Journal, where we have just frank change and destruction and signal change in your vertebral body. This is very consistent with tumor progression. But then you got something like this where you have treated this area, there's a T2 MRI, then you see some increasing signal change. What is that? Is that tumor? Is it progression? The patient's fine. It's pseudoprogression. And you have to follow these with serial MRIs. You cannot trust bone signal changes after radiation and MR, and I'm very quick to biopsy to prove it before I change management in these patients. Now we can, as I showed you, look at true progression and be confident of certain cases, and then what do we do if we've already treated them with stereotactic radiosurgery? There's this feeling that we can't do it again, or we have to give palliative radiation, and you don't. And we've actually been showing data now. So this is a case of RCC. We treated with stereotactic radiosurgery and got clear progression with epidural disease, paraspinal disease, and involvement in the bone. So this is a real deal. So what do I do in this situation? I'm not going to give palliative radiotherapy. This patient's still doing well in terms of performance status in their life. I'm going to retreat with another course of stereotactic radiation. Because if it didn't work the first time with that dose, how's it going to work with palliative radiotherapy? So we fractionate, but we go for 30 gray and 4 fractions. So we are being very aggressive with these patients because we understand the core tolerance now. And we published this report of salvage SBRT for infield failures. Now, it's important to understand that these are mainly low-grade epidural disease, 30 gray and 4 fractions, but seeing local control rates of 70 to 80%. And we provided you the spinal cord and cauda numbers for cumulative doses to help guide your practice. So very transparent. So I wanted to finish off with some innovations in the field, and it's really innovations with our surgical colleagues because we're working together now to improve outcomes. So a patient like this with some minor epidural disease, this patient's previous radiation, I want to maximize local tumor control there. I want to get rid of the epidural disease. So what do? Minimally invasive through a tube, go in, resect the epidural disease, then treat with stereotactic radiation, and there she is a year later. But what's important here is that we did this as an outpatient day surgery. Patients that comes in at 6 a.m., they leave at 5 p.m., and they go home. 2-centimeter incision, they're on the table for radiation planning within 3 to 4 days, and then they're treated 7 days later. A very nice, slick technique Eric Massicott, my colleague at Toronto Western, developed with our program. But it's really cool now, some of the new technologies with MR guidance, and this is laser interstitial thermotherapy, where they're going in and just ablating and burning the epidural disease and then getting out and then treating with stereotactic radiosurgery. Now you need about $25–30 million to build a suite in your OR, but still very innovative and really the concept of the future is there. Now, some of the other work that we're doing is that in these cases that have a baseline fracture and we want to stabilize them and use, say, kyphoplasty or cement augmentation if they're amenable, let's do it. But let's also give some localized antineoplastic therapy. So we're doing this with photodynamic therapy. So my colleague Albert Yee goes in, he puts his probe in there, we've developed a light activating probe in the spine, delivers the photodynamic therapy, then puts the cement in, closes up, and we give stereotactic radiation because still you're going to have 20% of your patients fail. So why not try and maximize local control when we're using an intraoperative procedure like a cement augmentation procedure? Now, Now, the last point of innovation that we've been working on is in the SINs. Like, I'm a big believer in SINs, and it's very good for communication, but there are some problems with it. And one of the problems is this issue of lytic or mixed tumor. Like, so if I have a little bit of lytic tumor, is that okay or not? Like, there's no metric here. And we like metrics. You know, we have the vertebral body collapse. At least that's somewhat semi-quantitative based on what you can judge. But how do you judge the amount of lytic tumor? So what we did was we've taken vertebral bodies, we've auto-segmented them with some software with a scientist I work with, Carrie Wine, and we're finding the amount of lytic and sclerotic tumor. You can use the adjacent vertebrae as your own in vivo controls and actually determine how much lytic tumor there is, and you can do the same thing for the fracture. So we're standardizing the metrics now. And we actually have a paper coming out for lytic tumor that, using our approach, the threshold of 11% predicts fracture, a 70% risk of fracture as opposed to under 30% if you meet that threshold. So very interesting, and we'll get there for the baseline fracture. So in conclusion, I'd say spine SBRT is an emerging field still. It's got great promise, but we need high-level evidence. We have the clinical practice. I love postoperative SBRT, understand better more the fracture and who should be prophylactically stabilized. And we're in the process of doing the randomized trials. It's tough, but we'll get there by working together. Thank you very much. Struggle with this also because the total dose really didn't play in. It was the dose per fraction. So the hard part here is your dose per fraction was single fraction. You know what that is, right? So the 20/24. So we were confident with that result. But, and this is why, you know, when we looked at 30 or 30 and 5 or 24 and 3, 24 and 2, the problem is there's so much heterogeneity in the dose that's actually delivered. This is just a number that we prescribe. Was it 80%, 90%, 50%? So I took the approach of dose per fraction because I thought, and I do believe that there's a threshold where this additive effect starts to happen of radiobiologically disrupting the tumor vascular endothelium and enhanced apoptosis and weakening of the bone structure. And so that's why I think the dose per fraction played out as opposed to the total dose. And I think it's more meaningful, actually, that it did. So there's a lot of issues, and we've looked at some of our data with even volumetric parameters like V90, D90, max, and it's just, we need big numbers to figure that one out. But at least we understand more the dose per fraction and the impact of high-dose single fraction radiosurgery, where you could say that fractionation is just safer, and that's a reasonable conclusion. Great. I think the main ways, you know, I learned it from my mentor in San Francisco, and I took it home and I built it. And I was in an excellent group with very high-level physics, which I think is really what you want to make sure that your center has, because your medical physicist is critical in the program development for spine SBRT. For brain, you know, you have the Gamma knife, you know, it's pretty, you know, no, you know, a neurosurgeon can do it, right? But the spine, they can't. Now, this is not their field. This is complex radiation oncology. So you want medical physics, you want a surgical colleague, ortho or neurosurgical spine, so that you can develop a multidisciplinary tumor group to discuss the cases. But then you need a little bit of training. So like Najman recently came and visited me. We have visitors from all over the world almost every single week. And you have to go there and you have to see it, because you can read the data, and it's just so complex in terms of what a dose distribution should be that you need to spend some time or do some courses. And I think that's the best way to start if you're starting fresh, you know, and to have your program validated. Like, I travel and I'll go to and look at a program and go through their whole program, give some feedback for a day or two, and then they feel more confident in going, because the last thing you want to do is hurt someone, and there is real potential for harm, but in terms of the fracture, not so much the cord. If you're not using a right technique, you can hurt the cord, or you're intentionally underdosing. So that's really where we are right now. But we're hoping with Electa to start a hands-on course in Toronto for people to come and really kind of learn spine and brain radiosurgery. Didn't show you was some of my algorithms, okay? And so my algorithm for someone who's got a baseline vertebral compression fracture, mechanical pain, and mechanical pain, but still fine to be immobilized and to go through the procedure, I'm going to do it first. And then at 6 weeks, we prophylactically cement them. And I push the surgeon at that point to do it, because if they're fine and they're no problem, many times the surgeon will say, well, why am I doing this? Because they don't want to intervene unless they have to. There's a risk to every procedure. The reason why I take this approach is when you shove cement in there, you can extravasate tumor as well. It's a small risk. We've reported it and seen it, but it's why I'll do it. So if they're amenable to do it, even if they have a baseline fracture, I'll go for it. Now, if they have mechanical pain to the point where they can't lie down to do the radiation, then it's worth that small risk of tumor extravasation. Let's do a cement augmentation procedure, or even better, which I really like, but it's more for the patient, is percutaneous instrumentation. I think it's very nice and slick. They just put it in there, but it's a bigger procedure. It's not an outpatient. They need to be in hospital for a day or two, but it's a much more nicer, stable construct over time. I really do like it. And the cement is good, and it's been durable, but they're disturbing the tumor, and I don't like that. So that's how I use my algorithms for stabilization. We still can't say this person needs to be prophylactically stabilized. It's still a judgment that you have with your surgical colleague. So our published limits are going to be adopted by the AAPM's guidelines now. They're widely in use in the SC24. So I know what's certainly safe. And it's been so safe, I am pushing it now in a systematic way by 10% higher. The MD Anderson actually has a cord finding study. It's very small numbers and somewhat flawed, but they are going a little higher on the cord. So as the technique is better and we understand more, we at least have a safe benchmark. And now it's about the high-level, academic centers starting to push higher in a safer way. So at least we know what's safe and efficacious.
All right, thank you very much.